Hello, everyone. My name is Adedapo Iluyomade, representing the Circulation COVID team. I'm a third-year fellow in cardiovascular disease at the University of Miami Hospital in Miami, Florida. Today, I'm joined by a very special guest, Dr. Eric Legome, Chair of Emergency Medicine at the Mount Sinai West and Mount Sinai Morningside Hospitals in New York City, New York. Thank you, Dr. Legome, for joining us today and being a part of the Circulation COVID Updates from the Front Lines initiative.
Thank you. It's great to be here. Thank you, Dapo.
So Dr. Legome, today we want basically to get your perspective on how your hospitals in the greater New York area have led initiatives to battle COVID-19. New York City has been at the epicenter of the pandemic here in the United States, and we really want to benefit from the lessons that you and your colleagues have learned. You're also our first emergency physician interviewee, and that alone makes your experience most unique and valuable. So to start off, many of the challenges faced by hospitals today are regarding the development and delivery of consistent treatment plans across the various departments. These departments are responsible for the care of COVID-19 patients from the time of presentation up until the eventual discharge. How have you dealt with these challenges, and what have you learned from your experience?
So let me start by saying what I learned. And probably the most important thing is, in the absence of really clear guidelines, the care will be disjointed, the care will be inconsistent. And we tried to start from the very beginning, and it was a very, very quick lesson that we found that there was a lot of information coming from all sorts of different sources, and people were doing different things. And to just give you an anecdote, I asked an attending about why they were admitting someone, and their answer was, well, the ICU attending told me that if they have this on their chest x-ray, everyone needs to be admitted. And so we found that in order to be able to plan, in order to be able to deliver clear, consistent clinical needs, and in order to understand our resource needs, we had to have people understand what to do with patients. And that doesn't mean that there wasn't room for clinical judgment, but in the big picture, there was a large number of patients who all were presenting with similar type of illness, at least in the very beginning. And so what we did is we formed the clinical guideline group, and it was a combination of emergency physicians who also lived within the ICU, emergency physicians who worked with medicine physicians, and we had them as kind of consultants, and they came and worked with us on our guidelines. We worked with them on theirs. We worked with infection prevention. And what we did is we had a regular meeting where we would put out to the entire group. And it's not just our two departments. We're part of a bigger system with 7 or 8 departments. And we would, every week or every week and a half, we would do an update saying, this is the basic way we want to look at all of these different things. So from the question of how do you disposition someone, who gets admitted, who doesn't get admitted, who gets a chest x-ray, who gets labs. And we did it based on, what was out there in the literature, what were we seeing around the country, what did our colleagues agree with, what did they not agree with. We didn't want to start something in the emergency department that was going to be completely changed on the floor in the ICU. So it really was a consistent, regular meeting with consistent overview of what's the best literature out there, what's the best theoretical ideas out there if we don't have clear literature, and then making sure that everyone was aware of what we were putting out. We would send it out to all the attendings, the residents, the PAs, and then post it on our website so they could get to it. What we didn't want to do is there's a ton of literature, or there's a ton of ideas on the listservs from the different specialties. People are sharing things. And while some of that's great stuff, we asked our attendings, send it to us, let us look at it, because we didn't want to have 15 different messages coming across the department.
Thank you, Dr. Legome. You mentioned resources in your answer to that question. How did your hospitals deal with the utilization of resources in a period of time when access and availability to those resources may have been limited?
So I think going back to the first question about thinking through the clinical pathways, if we knew that the best practice or the reasonable practice was we didn't need a resource, we made it clear to the clinicians this wasn't worthwhile doing or wouldn't add anything to your clinical judgment. So for example, CT scans, there was some literature from China where they use CT scans very early to make the decisions, and they kind of incorporated it into their workflow. But we realized that unless we were looking really for something different, it wasn't helpful. So we initially very quickly said, please do not use CT scans unless it's going to change something. Same with lab work. We decided there was a group of patients who could be discharged, and based on their premorbid conditions and their ability to follow up, we used resources for some for follow-up, but others to say we don't need to do labs. We don't even need to do a chest x-ray on them. And so as we built our protocols, we were able to say we could really limit certain resources and limit the need for people to get involved, and as people were some of our resources in taking care of patients.
Thank you. Thank you very much. For our second question, hospital ERs are oftentimes the first places to feel the overwhelming effects of a surge in patient visits for COVID-19. What strategies have you found effective for dealing with this and potentially increasing the ER's capacity?
Sure. Yes, and especially in New York City, we clearly feel that the space constraints. I would actually go back a little bit to the first question of how did we set up the clinical parameters and how did we set up our resource needs? And once we knew that, we realized that there's a large volume of patients who needed very few resources. And because we knew that, we were able to really expand into places we hadn't previously been. So, a lot of departments use tents for the low acuity patients and move things outside. We moved into different areas of the department that had very little supplies, but we really didn't need much. We did use things like some telehealth where we're able, by putting in a room and just having one person talk to them, we could decrease the number of people that needed to go in the room and save PPE, but also expand where we could put patients. And then also other places in the hospital, like the clinics that were not being used, we were able to utilize them for emergency medicine patients because they were well enough and we knew we weren't going to be doing many lab tests or interventions. So that's kind of how we kind of set it up. And then as time went on and the volume just kept growing and growing with the number of ill patients, we started to get, I think, a little bit innovative, a little bit creative. Areas that we previously used for patients that we never would have put an admitted elderly patient, pediatrics became a COVID zone. And because we knew, what we did is we looked every day to look at our volume in each area. And if we realized the patients weren't going to be going in there, we just reconfigured it into another zone. We also built certain pathways, and we're actually going back now and studying them to see how effective they were. And it looked like they probably worked well, to say that if we knew we couldn't get a test on someone for 12 hours or 10 hours and couldn't get it back in time, and I couldn't realistically separate the patients very well from each other, was there things that we could look at or variables we could look at that say that even though we don't have a test, this patient clearly had COVID? And so we used variables, we used age, we used bilateral infiltrates, fevers, et cetera, to be able to cohort patients. And we found that for the most part, we did not, our specificity was very, very high. We didn't put non-COVID patients with COVID patients.
Next, how has your COVID experience changed the way that you utilize multidisciplinary care teams, and how has telehealth been incorporated into emergency medicine at your hospitals?
So, it's interesting. So we had been talking about telehealth for, 2 years about how we're going to get this up and running. And the reality, we did it in about 7 minutes one day. We had the machines and we finally said, we're out of room, what do we do? And so we just put a machine in. So we used it in a couple different ways. One was in order to limit the number of clinicians that went into a room to preserve PPE, to make it safer. we would put a telehealth machine in the room and be able to talk to the patient and get a real sense once we knew their vitals, et cetera, to decide, do we need to do more? Can we just discharge the patient? We used telehealth for follow-up and hooked up patients who were maybe a little bit sicker than we would like to send home, or we wouldn't send home regularly, but we knew that it wasn't necessarily best for them to be in the hospital. And we were able to get telehealth follow-up for them within 24 hours, which was very successful. We used it for triage to be able to say, we don't necessarily need to bring someone up there, but someone could look at the patient, talk to the patient, and decide, do we need to use more resources or less resources? So we use it in various ways throughout the department. My guess is it's here to stay in some way, shape, or form, and we'll still continue to do that. We've also used it for some of our clinicians who were a little bit at higher risk, and we wanted to try to remove them when possible from the clinical area. And so they would be able to do some of their work through telehealth. And then lastly, we used it for patients to talk to their families. And that was, really a very powerful way for many people who were really struggling. How do you get the patients to be able to either say goodbye or really just have a conversation? And that was very, very useful.
Yeah, I absolutely agree with you that telehealth is here to stay. And as you can see, we're using some form of telecommunication now. But I think that going forward, that would be a big part of the way that we deliver care to our patients. So one interesting phenomenon that we've noticed across the country and around the world is that there's been a significant decrease in the presentation of acute coronary syndromes and strokes to the ED. Have you also experienced this, and what are your thoughts on the precipitous drop off of cases?
So my first thought is I hope they come back. We've seen this. We've seen this, talking to colleagues around the country, and just in New York City. This has turned from an emergency department disease to an inpatient disease and to a ICU disease, and they are very, very busy. We are not. Most of the patients we now see are actually quite ill, whether it's COVID or not COVID, but the large volumes we would see with stroke or stroke-like symptoms, cardiovascular symptoms, we're just not seeing. If you look at some of the numbers of patients that are dying at home, clearly they're way, way up. And I think there's some element of that where patients are just scared to come in and they're waiting too long to come in. And I think we were very successful in sending the message, don't come to the emergency department unless you need to. But I think people may not have understood exactly when they need to come. I would like to tell you a better answer. I don't think any of us truly know. We think that, clearly over the last week, some of the volume is coming back in some of the sicker patients, and we're starting to see what we expected. Some cardiovascular disease, diabetes, hypertension, that's slowly getting a little out of control. And so that's not surprising, but the absolute number of patients who clearly had strokes before just aren't there, or clearly had heart attacks.
Thank you.
Sure.
Lastly, we just want to wrap up with one more question. In your experience, what scheduling and logistical adaptations are effective in preventing burnout and exposure of the medical staff?
Sure. Well, so I would say one thing that I think is critical is really the constant and consistent updates to the medical staff, because I think a lot of their concerns were very valid, especially early on when really we didn't know what was going on. We didn't know how infective this disease was. We didn't know how virulent it was. We didn't know the best PPE, and that was changing constantly. So I think having regular updates was absolutely critical to hopefully mitigating some of the concerns that they had. And that's something I learned. I thought I was doing it quite a bit, and it turned out they wanted more. Other things we did is early on, we overstaffed a little bit. I think people weren't used to wearing PPE all the time, wearing masks all the time, and I think that was tough. And so trying to at least relieve some of the clinical burden where we could was very useful. I think getting other specialties involved, and they were incredibly helpful, and especially things where we didn't do all the time in the emergency department when it's certain critical care. And so they were involved with coming down to the emergency department, working with us. We had other services redeployed, which was very helpful. I think something that's very useful and I would recommend everyone has is, we call it the COVID police, but having someone in the emergency department who's someone that people trust and someone people who listen to, whose job it is to just walk around and say, you know, you're not doing this right. You're not donning right. You're not doffering right. You forgot to wash your hands. You don't need to do this there. Making sure there's lots of reminders, whether it's how to don and doff, whether there's, you know, if we didn't have room inside the room, whether there was a square right outside the room to be able to take off your gowns. And so the reminders help, the huddling and constant reminders verbally, and, you know, in addition to the pictures, but really having someone that people are willing to listen to and has the authority to say, you need to stop right now. This is not the right way to do this. And let me show you what to do. So it's not a punitive, it's a coaching, but I think it is absolutely critical. It may not need to be there every shift, but as people learn and get more and more comfortable, they need those reminders.
Thank you very much for that answer. So that's all for this episode of Circulation COVID updates from the front lines. I'd just like to thank once again Dr. Eric Legome, Chair of Emergency Medicine at Mount Sinai West and Mount Sinai Morningside Hospitals in New York City. My name is Adedapo Iluyomade, and we hope to have you check in with us once again after all of this is over, Dr. Legome.
Thank you very much. It's been my pleasure.